Good morning, everyone. Good morning, resident and fellows, and also attending at Indiana University, and also good evening, people from Thailand. So welcome back to the Learning with Indiana University on the episode 6 on the comprehensive review on non-accidental trauma. So this is a part of the lecture series that we do broadcast our didactic lectures from Indiana internationally to the people in Thailand and also Southeast Asian country that prove the concept that we can learn in the same time, same different pace, and this is like a borderless education. So today we have the speaker who is an expert in the child abuse, non-accidental trauma. Today we're gonna have like 3 lectures in total. We're gonna start with Dr. Holloran, who is an associate professor of pediatric, who is an expert in child abuse, and followed by my lectures on the imaging review on brain imaging on non-accidental trauma, and then Dr. Megan Marine that review imaging on the pediatric body that related to non-accidental trauma. So welcome Tara for the lectures.
Thank you. Let me see if I can share my PowerPoint.
Yes, please.
Sorry, I'm not as comfortable in Teams.
Yeah, I understand. You need to...
I have it open.
Yes. And then it is on the...
If I just share my screen, that works, right?
I can see your screen right now.
Okay, perfect. Then we'll do that.
Yes.
Okay.
I see it now.
So thank you very much for the introduction. And as mentioned, I'm a clinician. I'm a child abuse pediatrician. So I'm going to give kind of that background clinical piece. I understand that most of the people listening are radiologists, so I will keep that in mind. So just briefly, we're going to talk a little bit about child physical abuse and then some of the symptoms that we see in these kiddos who have head injury specifically. And then finally, I'm going to talk about a few discussion points, some of the things about documentation that I see come up in court or legal proceedings. So as you guys probably know, if you interact with kids or do kids imaging, child abuse is unfortunately very common in the United States. When we ask people as adults about their childhood, about 1 in 10 report some physical abuse before they turn 18. Every year, again in the US, about 5% of kids have a CPS investigation, and then 1 out of 5 of those are substantiated. So about 1 out of 5, or about 1% of kids have a substantiated case with CPS every year. And unfortunately, it's both common and deadly. It's one of the leading causes of death for little ones here in the US. So almost 2,000 children die every year, and they're mostly the little ones. So that is why it's so important we talk about screening for occult injury and when we need to screen these kids, because they can't tell us they have a headache, they can't tell us they're nauseous, they can't always tell us what they're feeling. So really important to know that kids with abusive head trauma can have the full spectrum of symptoms. Of course, some of them come in, having seizures and apneic, and we're pretty good at diagnosing those kids. But some kids come in really looking good with almost no symptoms, or sometimes they have no symptoms at the time we're looking at them. So it can be very easy to miss the diagnosis in those kiddos, and sometimes people don't understand why we want to neuro image them if they don't have any symptoms, but really important to know that kids with abusive head trauma can essentially have no symptoms. This was a study that I wanted to share that kind of changed clinical practice. This is a study by Dr. Lasky where they looked at of children with suspected physical abuse. If we do just routinely do head imaging, how often do we find occult head trauma? So all of these kids had no neurologic symptoms at all, just screening for occult head injury, but with other evidence of physical abuse. And they found that in the kids less than 12 months, almost a third of them had intracranial injury. And then with the kids a little older than 12 months, it was more like 25%, so a little less common, but still you can see very common. So this is kind of when we had a shift to screening routinely. So when we're worried about physical abuse, we routinely do screening for head injury in those little ones. So what prompts us to do that screening if they don't have any neurologic symptoms? Sometimes the concern can be social. So for example, if we know that infant has a twin who has evidence of abuse, we know that their twins or triplets, their siblings are going to be at very high risk, or other young siblings of an abused child. If there's some significant domestic violence in the household, we know that also puts the children at very high risk of injury. So sometimes we'll be screening them because of factors like this. Other times we may be evaluating them because of what we'd call a sentinel injury. And what a sentinel injury is an injury that looks minor, and to us as physicians is minor in that it doesn't need treatment. It doesn't need sutures or medications, or it doesn't need us to do anything, but it's a little red flag to tell us about what's going on with that baby. So specifically with infants who are not mobile yet, we really don't expect them to have any injuries or any bruises at all. So if they do have bruising, that's a big deal and tells us that we may need to be worried about abuse in this household. With infants, the classic trigger for abusive behavior is crying, and so we often see injuries to them, to their face. It's not a hard and fast rule, but often people kind of react to the part of the child that's frustrating them, and so we'll see injuries to the face, bruises like this on the soft part of the cheek and on the jawline. So you can see those are really quite subtle bruises, but they're a very important indicator for us and tell us that we need to screen for occult injuries. Sometimes they can kind of hide in little fat rolls. So this is a baby, another similar baby where you wouldn't see any bruises when you first look at him, but when you turn the face, you find a big bruise over the angle of the mandible. So sometimes they aren't seen at first, and we have to do a really thorough, detailed skin exam on these little ones. Aside from bruises on their skin, some of the other injuries we might see that would be sentinel injuries include subconjunctival hemorrhages. And this is an injury that a lot of physicians have a misunderstanding about. So when we see these in adults, not such a big deal, right? Adults can get these from coughing hard, crying hard, when we have upper respiratory infections. But the reason we can do that is because when we cough, when we bear down, we can generate quite a bit of intrathoracic pressure, and it can be enough to burst those little blood vessels. But this little one, she's 8 weeks old. She doesn't even have the trunk strength to sit up on her own, let alone to bear down so hard she bursts her own blood vessels. So we really don't have any evidence to support that young infants can bear down hard enough to do that. So sometimes I hear physicians say, maybe she was crying hard, or maybe she was constipated. We don't have any evidence to support that that's a cause for subconjunctival hemorrhages in young infants. So when we do see those in young infants, I tell my investigators to just consider it an eyeball bruise. We need to be worried about trauma. It can happen either from direct trauma to the eye or from suffocation type injuries. Another injury that is highly concerning for abuse in pre-mobile kids are injuries to the frenula. So we have one under the top lip, one under the bottom lip, and then one under the tongue. In older kids, once they're running around, they tear these when they fall down sometimes. It's usually an accidental injury in older kids. But in pre-mobile babies who aren't walking yet, if we see an injury to the frenulum, those are nearly always abusive. They get those injuries when, again, somebody's been frustrated with their crying usually, and they shove something in the mouth, they shove it in too far, too hard, and tear those little pieces of connecting tissue. We also see injuries to these with sexual assaults of infants. This is an example of a particularly significant, the lip is almost avulsed. This particular child came in with mouth bleeding. Baby was about 9 weeks old. And initially the provider who saw him thought that this might be a congenital issue, so had made a referral to ENT for several months out. As we know, congenital issues shouldn't just spontaneously start bleeding most of the time in a 2-month-old. So luckily this provider talked about it with another physician who said, I think we better send this kid in for more evaluation. And this baby had 17 fractures. You would not have known it from looking at the outside. This was our only little warning sign. So sometimes these warning signs of physical abuse can be quite subtle. This is what they look like as frenulum injuries start healing. They'll form granulation tissue. So when When they're fresh, they usually bleed quite a bit, but then quickly will start healing. And mouth injuries are always important to document because they do heal so fast. This is an infant who had a significant lip hematoma. The only picture we have is this one that mom took on her cell phone, although it is well documented in our medical records in notes, but I was glad she had the picture because by the time I got there to see the child in the morning, it was completely gone. So those mouth injuries can heal very quickly. They're still significant though, right? We still know it was there, so have to worry about other injuries. As I mentioned, in young infants, the bruises of abuse are often on their face, but not always. So bruises on a pre-mobile infant should raise our red flags for abuse anywhere. This type of parallel line is typically caused by being struck with an object like a belt or something that is that width. Again, we have a lot of misunderstandings about detection of child abuse. This baby had seen a primary care provider who had advised the family to just not swaddle her so tight. Swaddling doesn't cause bruises, right? I don't think anybody is ill-intentioned. I don't think anybody means to miss abuse, but sometimes when families are very nice or we've known them for a long time, it can be hard to see it. So it's really important to recognize these sentinel injuries when they're in front of us. So this is a classic sentinel injury. She did make it into CS and had a lacerated kidney below that, and then also had fractures in her lower leg over here. Similarly, this is a little guy who had bruises on his hips on both sides, and had a primary care doc who had known the family for years and just couldn't imagine that anything bad would be happening in the household. There was a new boyfriend with a toddler age child, and they thought, well, maybe the toddler kind of crawls on the baby trying to give the baby hugs, and so they were advised to just be really careful about the toddler around the baby. Of course, that's not really an adequate explanation for those bruises, and sadly, this little guy didn't come into us till about 2 weeks later when he had a devastating neurologic injury. So again, I don't think anybody wants to miss abuse, but sometimes it can be hard to recognize it. So we have to do our best to be objective and know that when we do see babies with bruises, we've got to be worried about abuse. This is another one who came in with this mark on the shin. The caretaker said it had been brighter red and was fading over the last couple of days. So again, that's an easy time for clinicians to miss abuse, because if it's getting better on its own, that's always a good thing, right? It usually means we don't need to do anything about it. But in this particular case, the provider didn't realize that this is a bruise and this is an 8-week-old baby. That's not normal to have a bruise. This is actually a classic squeeze mark. If you look at kind of the palm of your hand, the little triangles that are formed between the palm and the fingers are right here. And then as the fingers go out, you'll see the bruising go out to the sides where the knuckles are. So this is a classic squeeze mark. This baby wasn't sent in for evaluation and had some more subtle injuries, so had these parallel bruises that this is me convincing myself that's really a bruise and not just a line from the sheet. So I'm checking for blanching and showing that indeed that is a bruise. And then she had a very tiny bruise on her fingernail. Again, in an older child, in a 15-year-old, I don't know where they got that. They might have had some kind of accident, but in a 2-month-old, that's a very unusual injury. And so she was another infant who she was acting well, otherwise appeared well, but this is a map of all her fractures. She had fractures in her hands and feet, metaphyseal fractures in all the bones in her legs. She had rows of posterior rib fractures. So we have to be very cautious. Sometimes those signs that tell us something big is going on can look very subtle from the outside. This is another little one who had this little bruise on her elbow, otherwise no external injuries, and she had big subdural hemorrhages and retinal hemorrhages. So again, sometimes those external signs are quite subtle. So important for us to know that significant internal injuries may not be clinically detectable in kids less than 2. So even with a very good, thorough physical exam, we may not pick up any signs of their injury externally. So when we're thinking about physical abuse, we do need to evaluate for occult injuries. So in kids less than 6 to 12 months, we need head imaging, so either a head CT or a fast spin MRI. If there are findings, then we're going to follow that up with a complete head MRI and a complete spine MRI. But as an initial screen for occult injuries, either of these are good options. If they're less than 2, we're going to recommend a skeletal survey to look for fractures. And this guideline about screening for abdominal trauma is newer and not as clear cut, but less than 1 to 2. We'll do LFTs and a lipase to screen for abdominal trauma. We don't have to go straight to belly imaging. We can start with labs, and then if their LFTs are greater than 80, or if their lipase is elevated, then we'll recommend imaging. But if they don't have any abdominal symptoms and no abdominal bruising, then we'll start with those labs. If they do have belly bruising, then we're much more quick to go to CT. So a couple of other things that I wanted to mention as far as documentation. One thing that I know a lot of people like to do is stay out of court. So when you have very clear documentation, that is very helpful and will likely keep you out of court. So our team of child abuse pediatricians, we're usually in court about 5 or 10 times per month. And I think it's fair to say that our neuroradiologists and our radiologists at our hospital rarely get called. And that's in large part because of what clear documentation you have. So in other cases in court, you can't say, well, somebody else told me something, but in medical records, that's a typical part of how we practice medicine. And so they ask us, you know, is that how you typically practice, is to rely on their reports? And yes, it is. And so because we can read what you thought, and it's nicely documented, then usually you don't have to come to court yourself. So that can be really helpful. When we are giving opinions in these cases, we need to, again, make sure they're objective, which I think is easier from a radiologic perspective, where you don't have the family in front of you. So I don't see in radiology reports some of the things that I see in clinical notes. Sometimes I'll see things like, you know, I'm not worried about abuse because this family is very nice, which is, you know, not a way we rule out abuse, but also not something I think I've seen in a radiology report. So we do want to make sure we're basing our assessment on the injury and not any kind of social background. And then otherwise, you know, just making sure that what we are stating is evidence-based. So if we're making statements about aging of the injury or timing of the injury, or what the etiology is, we want to make sure that those are things that that the medical literature would support, and not just kind of what we think off the cuff. Timing is a big one, especially with head injuries. Our investigators always want to know timing. As a clinician, I really push for establishing a timeline of symptoms. I think that's most helpful for us in determining when a child's head injury might have happened. But of course, you know, with radiologic imaging, we do get some idea about timing. Just want to make sure we don't overcommit. You know, if you say, I think, you know, I can't tell you exactly how old this subdural is, but I think it's likely 1 to 2 days old. Your investigators are likely to latch onto that, and they're likely to look at who was the child with within the last 1 to 2 days. They really put a lot of faith in the statements we make. So again, we just want to make sure whatever we're telling them is really evidence-based, and we're not saying more than the imaging really says. And from the standpoint of kind of advanced neuro imaging, sometimes I think it may be helpful to correct timing statements that have been already made. So to give you an example, this is one that happens quite a bit. So if we have a child who's had a head CT at a referring facility, it's not uncommon for somebody to look at a head CT like this and to have interpreted it as acute on chronic, especially if they are general radiologists who have to have, you know, a degree of expertise in a wide range of things, and they don't necessarily look at kids' head imaging as often as our pediatric neuroradiologists who do that all day. So what happens is that this gets labeled acute on chronic subdural hemorrhages, and then the child gets transferred, and then that label sometimes sticks. So this particular baby, that happened. We followed up with an MRI, which showed that this was a subdural collection, but this child just had kind of prominent extraaxial spaces. So this was just CSF. So the child had one single age of subdural hemorrhage, but all the clinicians kept cutting and pasting what was in that report from the other institution, and so all their reports said acute on chronic, acute on chronic. So in this case, the entire defense was built on the fact that they thought there was more than one injury, and it became kind of awkward in court because they said, well, everybody else, all the other doctors think that there's 2 bleeds, and I said, well, not really. The neuroradiologist report also says that there's only 1 injury. So we got through it. There was a successful outcome, but if you have seen that label of acute on chronic, and then we get an MRI or you get a study that shows you there's really just one age of blood, being clear that we're correcting that there is really only one age is, again, really helpful for us from the clinical side. The other documentation issue that I wanted to mention, I think it's really helpful in the reports that when you are looking at them, like if there's a negative study, to say there's no radiographic evidence of abuse or something along those lines, where you're clarifying that you don't see evidence of abuse in the study you're looking at. Attorneys don't really always understand different physicians and what we do, and that we're commenting on a particular topic. So, for example, I had a child who had significant bruises and lots of injuries that were clearly abusive, but the attorney grabbed onto just a report from an abdominal CT that was negative. And they said, well, this doctor says there's no evidence of abuse. And I said, well, right, but they're reading an abdominal CT. They just mean on that study. Like, well, how do you know that? Well, because they're a radiologist and they're interpreting this study. So again, it's not a huge deal. We can sort it out, but it is helpful if you're, looking at a particular study and just clarifying that you don't see evidence of abuse on what you're looking at. We have it happen a lot. Like, this is a little girl who is a 15-month-old. She had bruises on the soft part of both of her cheeks. Her dad's story was that she had slipped getting out of the bathtub, which really doesn't make sense. If you slip getting out of the bathtub, you might bang a hard surface, but not so much the soft part of the cheeks and not both sides. So she did have imaging to screen for occult injury. She had a head CT, she had a skeletal survey. Those were negative. So again, that's a great place to say there's no radiographic evidence of abuse, because we do, in our overall clinical picture, we do have evidence of abuse, right? Sadly, our court system really hasn't caught up to understanding the significance of bruises. So she is one of our many cases where, because she didn't have any more extensive injury and these were felt to be kind of, quote, just bruises, there was not intervention, and she was killed a couple months after this. So really hard. It's anything we can do to help the court system understand that just because we don't find more extensive injuries, that doesn't mean we're not worried about these kids. It's really helpful. I'm not going to get into this too much. Just, there is a consensus statement on abusive head trauma in infants that is signed on, the signing agencies include the Neuroradiologic organization, American College of Radiology. I can't remember if the British group signed on or not too, but the AAP, lots of our professional organizations have signed on. So if you are involved with a case where you're going to be testifying about neuro findings, this is a statement you're likely to be asked about in court. They kind of expect us to be familiar with this if we're testifying as an expert in this area. It is a really nice consensus statement too for people who are or if you want to read more about these issues, kind of goes through some of the common other explanations that might be offered by defense, typically as explanations for the child's head injuries and why those are not reasonable. Skip through that, and then I think I'm kind of wrapping up. A couple of hodgepodge things that I wanted to throw in here. One, I don't know that we always recommend long-term follow-up and imaging specifically, but I think it's really helpful for us clinically to understand these kids' head injuries. So we have started trying to recommend, if we do make a diagnosis of abusive head trauma, to recommend re-imaging about 6 or 7 months out, or 6 to 9 months out. And it's very helpful both for us in determining kind of prognosis for the child and what kind of interventions they need, and very helpful for the courts to understand the extent of the injury. When we do have a child like this who on their initial head imaging may have relatively small looking subdurals, when we bring them back and their head looks like this, that's a lot easier for courts to understand about how bad this child's head injury is, and that they kind of get focused on the bleeding, and it's harder to explain parenchymal injury, but when we can actually show that, that's really helpful. So, and again, helpful for knowing what kind of therapies we need to get that child involved in. The only kind of other things that I wanted to show a couple of examples of, because I don't think you see them from the radiologic side necessarily, is that with abusive head trauma, about 85% of these babies will have retinal hemorrhages. I know it's pretty uncommon that you can actually see them on your neuroimaging. Sometimes if we have actual retinoschisis cavity, those will show up, but most of the time these will not show up. Just for a refresher, this is what our normal retina should look like. And in these kiddos with massive retinal hemorrhages, we'll see hemorrhages in multiple layers. So these are intraretinal hemorrhages where they're within the retinal layers. This is a big pre-retinal hemorrhage where it's out in front of the retina, but inside the internal limiting membrane. You can see the blood can kind of pool. And then some subretinal hemorrhages that are deep underneath the nerve layers. So these are classic appearance. This is the classic appearance of retinal hemorrhages in a case of abusive head trauma. Not all retinal hemorrhages are classic though. So this is a classic appearance. Sometimes kids will have more non-specific retinal hemorrhages. So these are intraretinal and there's just a couple of them. This appearance kids can have after CPR, after any resuscitation. We don't really see them after, sometimes people wonder about seizures causing them or hypoxia. We don't really see them in those situations, but we can also see them with sepsis and leukemia and some other medical issues. So sometimes they have retinal hemorrhages that are quite specific for abusive head trauma. Other times they have retinal hemorrhages that are not as specific. And then the last thing I wanted to show you, again, just because I don't think you get to necessarily see it from the radiologic side, is just to show you what the gross appearance looks like of these hemorrhages. So sometimes when we see babies with these subdurals on head CT, it doesn't look like a whole lot of blood. It's a relatively small collection. So my next pictures are from autopsy to show you what this looks like grossly. So this is this particular baby's head imaging. You can see it's actually quite a lot of blood. So before you see it on your head imaging, there's quite extensive hemorrhage, or quite extensive hemorrhage collected before I think we see it on that head imaging. This is showing that left side collection, and the right, which really doesn't look very impressive, is quite impressive, unfortunately, at autopsy for this child. So that was my clinical overview. Let me figure out how to stop sharing. And I can take questions, or of course I'll stay on if there's questions that are that come up later.
Sure. Thank you so much, Tara, for giving us like a comprehensive review on the clinical presentation. And I like your couple slides on the documentation, on what we should say or what we should not say in our report. I think that is very important for us to have that in mind.
Really helpful, and I appreciate your attention to documentation. It's super helpful in our cases.
Yeah. Any questions from the audience in the classroom and also on the team? I have one comment, Tara. So I think like in the US and particularly at IU, we don't have any issue about, not that many issue about child abuse that we need to go to the court, because we have the good team like you guys to help us on the clinical aspect and go to the court and testify for us. However, recently I just got a consult from people in Thailand, and actually I have like the Thai doctor in this chat room with us, Dr. Namphon Sinchai. So she is a radiologist. So recently I got a consultation from the people, from the radiologists from Thailand. And she saw the findings, and she thinks this could be like a child abuse, but because of like in terms of the medical care and like the team in Thailand for the pediatrician who can strongly say this is a child abuse or something, it's a little bit difficult because I would say like a majority of the Southeast Asian country, they don't have like the strong support system in this part. Do you have any like a recommendation or like how they should approach on this thing, and we can have Namphon to like share her comments here too.
Yeah, I think that's a great point. And at our center, we have 5 board-certified child abuse pediatricians, but we are the only ones in the state of Indiana. So even in the rest of our state, it's not a resource that other radiologists or other docs necessarily have on site. I will say that because we know there's only about 350 of us in the world, and so we are used to helping others. So we quite frequently consult on kids who are not here at our own facility. So within the U.S., if people are practicing at an institution where they don't have a child abuse pediatrician, they can find one who's the closest one, and we will usually help. Outside of the U.S., I think that's a lot harder, and I know laws are different about child abuse, and how their cases are prosecuted or not prosecuted are different in different countries. I think if your radiologist wanted to talk through a case, I think one of us would be willing, very willing to talk about the symptoms and what we think about the situation. As far as like needing somebody to testify, that usually falls onto the prosecutor. The prosecutor has to decide, and they can, hire an outside expert and hire somebody to come testify. But yeah, obviously that can be challenging, especially if there's not someone close. So I know in some places the radiologists do get called to testify a lot. And one of my good friends is a critical care doc who works at a hospital that doesn't have a child abuse doc. So when they have an abusive head trauma case, she gets called to testify, the neuroradiologist gets called to testify, the radiologist gets called to testify, and it pulls a lot of people out of the hospital. So it is a relatively good financial investment for the hospital to have us if they can.
Yeah. I think that is really difficult because I mean, like that radiologist who called me, I said this is likely to be child abuse, but it is like some soft call from the clinician that, oh, I see some bruises. It's maybe they cannot like specifically say, oh, this is likely to be child abuse on the physical examination.
Yeah.
But what I'm getting is like, oh, it's likely for us, like we see like subdural collections, like different signal intensity, maybe like a two event that happened or something. But on the clinician side, it's yeah.
Yeah. And sometimes we don't have enough evidence to say one way or the other, and those are the kids that give me more gray hairs because I don't know what to say.
Yes.
You worry about them.
Yes. Namphon, do you have any comments or session?
It's very helpful for this lecture. I appreciate it because you give me a hint for reporting, like no radiologic the evidence of child abuse instead of no evidence of child abuse in the report. It's very important to protect us and like to describe clearly.
Yes. Thank you so much. Yeah. So Namphon is a radiologist in Thailand, and she's planning to be like a forensic radiologist. She's going to like study abroad for the forensic radiologist.
Oh, that's great.
Yeah. Thank you so much, Tara. So I think Megan is driving right now, so I'm gonna start my lecture first, and then she will come after my lectures. Let me try to share my screen. Okay, so now I'm having an issue. Share. Can you see my screen?
Yes, I see your screen clearly.
Okay, so we're gonna switch gear a little bit on the imaging finding in neuro for the child abuse. So outline today, I'm gonna give you some imaging checklist for the brain, for the spine, and we're gonna talk a little bit about the protocol and sequences. That is like a problem-solving sequence for us here at IU. So I think Tara already mentioned about like the incident of the non-accidental trauma already. One thing that I want to highlight here is abusive head trauma is the most common subtype of non-accidental trauma and leading cause of traumatic brain injury in children. So why children has like more susceptible for the traumatic brain injury? When you look on this diagram, you can see that the kids has a bigger head to the body ratio and also has a thinner skull, has an incomplete myelination, and has a greater incidence of diffuse injury. So for the pediatric non-accidental trauma, some clinical clue that the clinical team can suspicious for child abuse, including like injury in non-ambulatory, injury and history given are not incompatible, and delay seeking for medical attention. This thing Dr. Holloran is already tell us. But for radiologists, one clinical history that we should aware of child abuse is macrocephaly. And also, this patient more likely to have like a diffuse brain injury, including the patient who has like a skull fracture, subdural hemorrhage, subarachnoid hemorrhage, diffuse external injury, and brain contusion and hypoxic ischemic injury. So in terms of imaging modality for the brain, so what do we have in our hands? We have ultrasound, CT, and MRI. So ultrasound is good for the open fontanelle, and patient with macrocephaly can be the first screening to look for macrocephaly if there is any like a subdural collection or not. CT gives you like a good detection for the hemorrhage and skull fracture, but the detail of the brain parenchyma is not that good. It's easy to get access, no sedation or GA needed, but it's come with the radiation dose. Compared with the MRI, which can give you the better imaging resolution and details on the brain parenchyma, extra-axial collections, but the detail on the bone is not that good for the bone fracture and may need sedation or GA. But the good things for the MRI is like a no radiation dose. So majority of the child abuse patient, we're going to focus on CT and MRI. Imaging checklist for the brain findings. The first one, you need to differentiate between BESI and subdural collections. So what is BESI? So BESI is a benign enlargement of subarachnoid spaces of infancy that usually like an idiopathic enlargement during the first or second year of life. And it happened because immature drainage pathway of the CSF that the arachnoid granulation does not know exactly how much they should absorb or like secrete the CSF. And it's also the improper development of the brain and skull. So the main thing for BESI is macrocephaly with no neurological symptom, and it is a spontaneous resolve by age of 2 years old. On the MRI that you can see here, imaging checklist, you can see like it's usually symmetric. You can see like the vessel or vein crossing through that space. And the patient normally have the normal or mild enlargement of the ventricle, and has a normal development and no prior brain injury, no neurological symptom, and often has a macrocephaly. It usually presents during like 2 to 7 months and resolve at 2 years old. Compared with the subdural collections, so for the subdural collection on the ultrasound, you can see the two separation of the collections here. The first one that we have the star overline, that is a subdural collections, and the underneath that is like a subarachnoid spaces. So normally on the ultrasound or even like a MRI, you should not see the vessel that crossing through that space. On the when you see subdural collections on the imaging, it many possibility. First thing that you need to rule out is child abuse, but it can be complication of the CNS infection like a subdural empyema or reactive subdural collections. So you need to look for like the dural venous sinus and also like the vessel that passing through that space. So in summary for BESI and subdural collection that related to child abuse, so imaging checklist is like for child abuse, you can see maybe multi-stage product has a massive to the adjacent brain parenchyma compared to BESI, which is like the physiologic development, which is idiopathic enlargement of subarachnoid spaces. It usually resolved by 2 years old, macrocephaly with no neurological symptom, and you see the vessel in that area, no mass effect. We can use CT, MRI, or ultrasound in detect BESI, but sometimes CT cannot like tell you 100% between like a BESI or low density subdural collection. So this is the images that I got from the StatDX on the BESI, that is an enlargement of subarachnoid spaces that has a vessel passing through. So normally in my report, I normally put enlargement of bifrontal subarachnoid spaces, possible BESI in clinical setting of macrocephaly with no trauma. However, BESI can be predisposed to subdural hemorrhage. If the patient has like a very big space of the subarachnoid spaces and maybe has some like a minor trauma, but every time when you see BESI and you see collection, you need to rule out child abuse first. Number two, you need to differentiate between subdural hyperoma, chronic subdural collections. So what is the difference between subdural hygroma and chronic subdural collections? For the hygroma, it's a collection of the CSF with no drug product. It is like the tear of the arachnoid radius, forming of the bowel valve, and open to allow the CSF leak to subdural space. And most common cause is a sudden decrease in the pressure as a result of maybe like a shunt placement, and that's why patient has a CSF leak in the subdural space, and the incident increase in the patient with a moderate to severe brain atrophy compared with the chronic subdural collection, which is a resolving of acute subdural hemorrhage. Imaging modality like ultrasound, CT, and MRI cannot give you like a 100% differentiate between subdural hygroma and chronic subdural collections. So in my opinion, when you need to read like a non-accidental trauma patient and you see some collections, I'm trying to avoid the term subdural hygroma because we cannot see the real pathophysiology on what happened. I normally put like the general statement like a chronic subdural collections and give them the signal intensity on the imaging that we see. So how about this patient, 6-month-old with macrocephaly? I have a choice for you. Could it be like a BESI, subdural hygroma, or chronic subdural collections? So when you look on the CT, there is like an extra axial collection, right? Relatively hypodensity when you compare with the CSF in the ventricle. So I mean, in this one, I'm gonna call chronic subdural collections or hemorrhage. I won't call like a subdural hygroma because we know that this patient likely to concern for child abuse. The same patient, we have the imaging on the MRI on the FLAIR images that we see the density of the subdural collections, bilateral convexity, and also this patient has a retinal hemorrhage. Number 3 that we need to do on the checklist on the brain imaging is contusional tear. So what is contusional tear? Let's look on this patient, which is a 2-month-old, fall down. On the CT images, we don't see any like a big hemorrhage or parenchymal hemorrhage in here. Maybe some loss of brain wide differentiation on the frontal, parietal, occipital area. But when we have the MRI, on the MRI study, the first row that is a T2 image, and this one is a SWI. Are you able to see my like a cursor here? That is a SWI and also like the ADC images here. So on the ADC images, okay. So on the ADC images, you can see like that the restricted diffusion in the cortices in the frontal and parietal lobe. So that is the HIE things. And on the SWI, you can see some susceptibility artifact in the frontal lobe, like a frontal subcortical white matter. And when you look closely on the T2, that hemorrhage has some cavitary lesions and has a layering fluid over there. So this is a contusional tear. So what is a contusional tear? It is a parenchymal laceration that usually happen in the subcortical white matter and gray matter. When usually happen in the children less than 5 months old or incomplete myelination. It happened because of the shearing injury of unmyelinated subcortical white matter and gray matter that has maybe like an acceleration, deceleration, and has like some tear of that junction, so that it forms like a cavity and has a layering fluid. So it is a unique and specific finding for child abuse that we see in about like a 13%. So which means like when you see like this contusional tear in the brain imaging, you can say with confidence that this is a specific finding for child abuse and concerning for non-accidental trauma. The 4th checklist is a hypoxic injury, like this patient. This is a 2-month infant, previously healthy, and concerning for child abuse, right? So on this one, on the CT images, you can see there is some loss of brain by differentiation of the cerebral hemisphere, also small amount of subdural hemorrhage along the interhemispheric box and also along the right pentalium cerebelli. And on the MRI, it's confirmed your findings that there is a diffuse restricted diffusion within the cortices of the right and left cerebral hemisphere, and maybe some some hemorrhage, a little bit of hemorrhage in the south side, and possible maybe some in the parenchyma. And on the physical exam, there is a bruise on the left upper arm and also bilateral retinal hemorrhages on the ophthalmologic exam. And patient passed away after the event. So the fifth checklist on the brain imaging is the tadpole sign. What is the tadpole sign? So let's look on this study first. This is the 8 months old with macrocephaly. This is a formerly preterm baby. On the brain images on the axial and coronal, you can see large subdural collections has some relatively high potency when you compare with the CSF in the ventricle. And there is some linear stuff here in the right frontal or maybe parietal convexity over there. And when you look on the MRI, on that linear stuff, that is a vessel that passing through that CSF space, but it's like an irregular shape thing. So that is like the thrombosis and maybe like a torn of the breathing veins. So that's why we have the subdural collections and has this appearance of irregularity. So what is the tadpole size? So tadpole size is the acceleration, deceleration of the breathing veins that has that create the subdural hemorrhage and has a thrombosis within the breathing vein or around the breathing veins that look like an irregularity and maybe have some big head or something look like a tadpole. So this side is not pathognomonic but supportive of the child abuse. And the last one for imaging checklist for the brain is the skull fracture. So for the skull fracture, look on this patient, 2 months old, found out that we see maybe some loss of brain by differentiation. But when you look on the bone window, you can see the fracture of the right parietal bone. I think for us at IU, we normally do the 3D reformatted images. So at least by this image sequence things, we can see the fracture better and can see the extension of the fracture better that involve the parietal bone and may have some extension to the superior sagittal suture, like a sagittal suture. I would like to introduce you to one sequence that we can see the bone better on the MRI. So this is another patient that we have the CT images on the bone window that we see the fracture in the left parietal bone on the axial and coronal image. And here at Riley, we normally do the technique that we call Petra technique or backbone technique. So by this technique, we're trying to create the imaging of the bone on the MRI using the technique that we call ultra short TE. When you look on the parameter here, the TE is only 0.07, so which is like a super short TE. And by this technique, we can create these images. And we are able to see the fracture here in the left parietal area. We are trying to simplify that things by making it like the images look like the bone window on CT that the bone should look bright here. So we do the inverted Petra technique and we can see the same thing, and we can also do the reformat images. So we had a paper published like a couple years ago on this technique, and we found out that the backbone sequence can give you the high sensitivity and specificity for the detect of the skull fracture in children with the abusive head trauma. Okay, so for the imaging checklist of the spine, for the spinal cord injury, so the incidence for the spinal cord injury is low in children with a couple things, because when the children has like a trauma, like a spinal cord trauma, it usually happens with the spinal cord itself. Half of the children with the spinal cord trauma die at the scene because of the Fulcrum point, as we know that head to body ratio is high in children. So in young children, the Fulcrum point is at a C1 to C3, and in adolescent it's like a C5 to C6. Are you able to see my screen here somehow? And half of the patient with a spinal cord injury usually associated with a traumatic brain injury. So look on the imaging modality that we have for the spine. We have the preradiograph, we have ultrasound, CT, and MRI. So ultrasound for the spine is probably not useful at all for the bone. We cannot see the bone very well on the ultrasound, and it's also time consuming. On the radiograph, when necessary, we can use the radiograph as a first line for imaging of the cervical spine to clearance the children. So I think like the majority of the modality that we use is a CT and MRI, which is good for fracture. However, for the CT, we cannot see the detail on the ligamentous injury or the cord pathology very well. And on the MRI, we can see the detail of the ligamentous injury and cord contusion better. It gives you the fair detail of the compression fracture and marrow edema, but the downside for the MRI is it needs sedation or GA. So if you want to check for the cord signal abnormality, cord contusion, and ligamentous injury, MRI is the way to go. So for the spine, the first thing that we need to check is the craniocervical junction ligaments. So let's review the anatomy first for the craniocervical junction ligaments. So I normally look on the sagittal image, which is we normally have the T2 3D images at Riley. So on the sagittal image, the first ligament that you need to check is the tectorial membrane. And on the coronal image, you need to check the transverse and alar ligaments. So for the transverse ligament, is a ligament that cross between the C1, lateral mass of C1 and C2. And for the alar ligaments, it go up from the C2 to the occipital condyle. So looks on these images, sagittal T2, the first ligament is an apical ligament that connect between the tip of the crivas to the tip of the dens. And then the tectorial membrane is the membrane that forms the posterior aspect of the crivas and connect to the posterior aspect of the dens. When that ligament's going down, inferiorly, we call that things posterior longitudinal ligaments. And then on the anterior aspect, we have the anterior atlanto-occipital ligaments. And when it go down, we call the anterior longitudinal ligament. And on the posterior aspect, we have the posterior atlanto-occipital ligaments that connect between the occipital bone to the C1 and C2. And when it go down, we call ligamentum flavum. So this is on the sagittal images that you should be able to identify these ligaments. Look on this patient. So what do you think? This is maybe like a more adult patient with a car accident, but I think this is a good image to show you when you want to identify the ligamentous injury. So on this patient, on the sagittal image, the first thing is you see the disruption of the tectorial membrane, you see the disruption of the apical ligaments, and also the disruption of the anterior atlanto-occipital ligaments. And when you look on the coronal image, there is missing the connection between the occipital condyle and the C2, that is a disruption of the alar ligaments. But when you look on the transverse ligaments that connect between C1 and C2 is still intact. And you can see like an extensive soft tissue edema and also the abnormal signal intensity within the spinal cord that has a cord contusion. So in this patient, it is a C1, C2 dislocation in the trauma setting. This is another patient that has some trauma. So the first thing that we can see here, let's check on the tectorial membrane, there may be some disruption or maybe like a contusion of the tectorial membrane because you don't see like the whole dark signal of the tectorial membrane. Apical ligaments, you cannot see it very well. On the anterior longitudinal ligament, it looks intact. Alar ligament is like some abnormal signal intensity, maybe some fluid in the alar ligaments on the right. Transverse ligament looks intact, and when you look on the cord, there is also cord signal abnormality. So in this patient, they has like a right-sided cord contusion and also alar ligaments injury. In this patient, same thing when you check on the transverse and alar ligaments on the coronal image. So you can see there is some abnormal signal intensity on the ligaments that connect between C1 and C2 and also on the alar ligaments. So there is some edema of the right transverse and alar ligament injury. So that is maybe like a more obvious imaging findings on the craniocervical junction ligaments in trauma patient. But I just want to show that things to you. At least you have like the imaging of the normal and abnormal finding of the craniocervical junction ligamentous injury in your mind. But the second checklist is like a more related to child abuse patient, which is like a subdural, epidural, or subarachnoid hemorrhages within the thecal sac. So how can we know this is like a very small space within the thecal sac, which is sometimes quite difficult, in my opinion, to differentiate between like a subdural, subarachnoid, or epidural hemorrhage in this area. So first, let's go to the drawing diagram here on the thecal sac. So first thing that you can see here on the blue color here, that is a dura. And next to the dura, which is a red color here, that is an arachnoid matter. Passing through the arachnoid matter, which is a yellow fluid here, that is a CSF. So which means when you do the lumbar puncture, you poke the needle in passing the dura and arachnoid matter, and your needle is in the yellow area here, which is a CSF. And then you can see like the spinal cord over there that has like the green membrane over there that we call a pile matter, which is like a sit next to the spinal cord. So when you have the cross-up images on this one, on image B, when you look on the CSF space over there, so normally in the CSF space over there, there is a ligament that connect between like a pia matter and arachnoid matter. That we call the dentate and also like a dorsal septum. It's like the ligament or maybe like a septum inside. So which means if the patient has some hemorrhage, like subdural hemorrhage, so the appearance of that subdural hemorrhage within the thecal sac or within the spine usually have like a concavity or lobulated contour because of that membrane or the septum. So look on the real imaging here, which is on the first one, we have the sagittal T2 and also the axial T1 image. On this one, I want to show you the subdural hemorrhage. So let's look on the sagittal image. There is something extra, right? You can see like some dark signal here within the thecal sac at the thoracolumbar level, and you can also see the triangular shape epidural fat over there. And when you confirm on the axial images, that hemorrhage look like a lobulated contour, and you can see the free, like a clear space on the epidural space. So this is subdural hemorrhages, which is quite most common findings on the non-accidental trauma. Compared with subarachnoid hemorrhage, which is the hemorrhage within the thecal sac, which in the CSF space when we normally do the lumbar puncture. So that's why when you see that hemorrhage in that CSF space, you usually see like a layering CSF fluid level. Compared to the epidural hemorrhage, which is a hemorrhage within the epidural fat. So normally everything has to push up, and you lost the epidural fat posteriorly, and also that hemorrhage, that hematoma push everything in the thecal sac anteriorly. So in terms of the spine injury, we did the research here at IU, and we found out that the most common injury for the spine is a subdural hematoma. The second most common is like a ligamentous injury, about like a 10%, and then we have like a vertebral fracture, subarachnoid hemorrhages, epidural hemorrhages, and cord contusion. And in terms of the location within the spine, about 50% of those injuries usually localized in the thoracolumbar spine. So this turned out that we changed our protocol for the child abuse patient. Instead of doing just an MRI cervical spine, we do it as like an MRI total spine. Since we know that majority of the finding in the spine usually localized in the thoracolumbar and it's likely to be subdural hematoma or hemorrhage. Any of my fellows want to take this case? Any of my fellows interested in taking this case for the hemorrhage in the spine? If not, I can walk you through. So this is a sagittal T2 3D image, sagittal T1 and sagittal stir, and I also have the axial T1 and T2 for you. First thing that you can see here, there is some collections, T2 hypo-intense collection within the maybe thecal sac. So you want to see if this is a subdural or subarachnoid or epidural. So first you can check at the dorsal epidural fat on the T2. The dorsal epidural fat looks clear. So this is less likely to be the epidural hemorrhage. So it could be like a subdural or subarachnoid. And when you look on, it also shows some like a lobulated contour on the sagittal image, and also the lobulated contour on the axial T1 and T2 image. So this make the findings likely to be subdural hemorrhage. Right. And I just want to show you the sequence that I like to detect this subdural, epidural, or subarachnoid hemorrhage is the gradient, axial gradient, because on the axial gradient, you can see susceptibility artifacts very well and outline that hemorrhage. So I think the axial gradient is a must on the protocol for you to look for any like a hemorrhage within the spine. How about this patient? Let's check. We have the sagittal T1 T2 and stir and T2 and axial T1, T2. So on this one, you can see the epidural fat looks good, right? And there is some like a collections anterior to the epidural fat. And we need to think, oh, that could be like a subdural or subarachnoid. But on top of that, on the stir images, there are also some subdural things, collections in the ventral epidural space. And we can confirm that findings on the axial images, T2 and gradient, that you can see some subdural hemorrhages in the ventral and dorsal epidural space. The third one, imaging checklist for the spine is the spinal cord, because we need to check for the cord contusion every time when we do the study here. So on this one, on the sagittal T2, T1, and also stir, we also see abnormal signal intensity within the spinal cord over there. And on top of that, in this patient, also have maybe epidural or subdural hematoma at the lower thoracic and lumbar spine. And on top of that, in this patient, we also have like some compression deformity of the vertebral body, that there is some mild deformity of the vertebral body of the cervical and upper thoracic level. And on the axial images, we confirm the finding of abnormal signal intensity within the spinal cord. Right. The fourth one is a fracture of the spine that I already showed you in the previous case. This is the same one that is really challenging to call like a spinal fracture in children, with two reasons. The first one is because children or baby still have like an ossification center and also development of the vertebral body. So that's why there is like a lot of variation on the vertebral body. The second one is in children, the marrow, mostly red marrow. So which is very difficult for us to detect any edema within the marrow. On the stir images, that's not really helpful to detect like a marrow edema, because majority of the marrow is a red marrow. So that's why we need to like pay attention in the shape and any like abnormal configurations of the vertebral body, like a concave configuration here, like in this patient, and also other associated findings. So this one has like a compression deformity of the lower cervical and thoracic spinal cord, and also has some cord contusion. So for the protocol and problem solving sequence, I think Tara already mentioned, when we have the patient with suspected child abuse, we normally do like a skeletal survey. And if the patient has like a neurological symptom or suspicions for any trauma within the brain, if the patient less than 2 years old, we're gonna get the CT with the 3D reformatted images. The reason is because when your patient less than 2 years old, the bone, the skull is really thin. So it's really difficult for us if we have only like the cross-sectional axial, coronal, and sagittal CT to detect the skull fracture. When we add the 3D reconstruction, it increase the sensitivity to detect like a fracture better. And if the patient more than 2 years old, we can just do the CT head. And then we proceed to the MRI brain and total spine. For the MRI brain, normally our routine protocol include the axial T1, T2, 3D, blah, blah, blah. And then we also add the Petra sequence to detect any skull fracture, and at least help us to have like a learning curve to compare the imaging on CT and also imaging on the Petra sequences for the fracture. And also for the total spine, we normally do the sagittal T2 3D, which is a good sequence to detect for ligamentous injury. We normally do axial gradient to detect for subdural, subarachnoid, or epidural hemorrhage. And we normally do the sagittal stir, axial gradient, and sagittal DWI for any like a cord pathology. So in summary, for the imaging checklist for the brain, first thing you need to differentiate between BESI and a subdural hemorrhage from child abuse. You need to trying to avoid the term subdural hygroma, trying to use the term of chronic subdural collections. You need to familiar with the imaging finding of the contusional tear, which is a cavitally with hemorrhage at the subcortical white matter, which is a unique and specific finding for child abuse. And also the TAT prosa, which is a cortical vein thrombosis or bridging vein thrombosis, which is a supportive evidence for child abuse. And also you need to check for hypoxic ischemic injury on the DWI and ADC images, and for the skull fracture, that on the MRI we can use a Petra technique. So all of this finding should raise your suspicion for the potential child abuse. And for the spine, you need to check for the craniocervical junction ligament dust injury, and the key sequence is a T2-3D. Also check for subdural, subarachnoid, and epidural hemorrhage. Checking for vertebral fracture, any compression deformities or abnormal signal intensity on the stir images, which in my opinion, I think is quite difficult to detect marrow edema. And also check for cord contusion. For the protocol CT, we should do CT with the 3D reformatted images for the skull fracture. MRI brain, we should almost always add Petra to detect the skull fracture. And also for the spine, T2-3D of the spine for the craniocervical junction ligament dust injury, gradient for the hemorrhage, and DWI for cord contusion. I think that's it for me. Any questions, comments?
Tanya, that was a great review.
Thank you so
I
much.
have a couple questions.
Sure.
So one question is when we're doing head ultrasound for macrocephaly in an outpatient, it's not too uncommon that we encounter subdural collections. It sounds like from what you discussed early on, the recommendation should be for MRI and not an initial head CT because that is not probably likely going to give the answer. Is that true?
Not really. I think it depends on how suspicious you are, Megan, because sometimes, in my opinion, I still feel like the chronic subdural collection is really difficult on CT. So if you need to choose between like a CT and ultra-fast MRI, I would recommend ultra-fast MRI.
And at what age up to can you do the ultra-fast without sedation?
So normally it's up to 6 months, which may be like at the same time frame that you can do the ultrasound because of the open fontanelle, right?
That's a good point. My second question is, have you tried using the Petra black bone sequence on the spine, or is that useful?
We did try that one, but I mean, I think it's because it's like a lot of detail on the spine. And for the fracture, it's maybe a little bit difficult. Yeah, we did try a couple times. But we can revisit on that protocol again if you think like for the spine variation that we are doing right now, that may be helpful.
I don't know. I guess it's something to think about.
Yeah,
I think the vertebral body fractures are, like you said, unfortunately challenging.
Yeah. It's maybe useful even like revisit that things again and maybe do comparison with the patient that we have. Maybe, yes. Okay. Thank you so much. So the next session we're gonna have like 45 minutes for Megan on the review imaging of the skeletal survey and also like other body imaging that related to child abuse. So welcome, Megan.
Yeah.
Thank you so much.
I'm happy to be here. I need to switch audio from my phone to my computer. So give me like 3 minutes to do that and I'll be right back.
Sure. So in the meantime, any questions from the audience or any comments? I will send you guys an evaluation on the chat box, and Rhonda will send that things to you on the email too. So please complete the evaluation for us so we know what we can do better next time or any topic that you want to learn from us. And for the audience from Thailand, we will send the evaluation to you to your email. So please complete that evaluation by the end of this week to get the CME credit.
screen, I'm going to advance to the next slide. Is that, do you see the no disclosure slides in a PowerPoint format?
Yes, I think so. But I mean, your screen is in the upright position, right?
Yes.
Like the monitor, okay. Because that's why like the screen is relatively small.
I'm at Riley, and so this is my only option.
Okay, sure.
Is it really small?
It's relatively small, but I think it's probably okay. Yeah.
I can try to
Like switch the monitor, something to like the big monitor.
They're all up. Unfortunately, they're all upright.
Okay.
Let's see if we can.
Are you in the reading room or?
Yeah, I'm in Fluoro.
Okay.
My office unfortunately has the same computer, so.
Okay. Because normally in the reading room we have like the big screen. It's like the maybe 32 inches or something on this side, right? But I mean, this one I think this should be okay.
Let me try to switch it over to the other screen. Let's see. I don't know why it's going to that screen.
There's maybe like a swap monitor or something when you share the screen, like a display setting or something. Let's see. On the top, like a display setting, and it's like a drop down menu that you can swap the presenter view and slideshow.
Okay, let's try that. Yeah, unfortunately, I'm not seeing that option.
Oh, that's okay, Megan. I think like we can see on that like an upright screen.
The other option is to use a little bit wider screen, but it's not going to be in the presentation mode. It's for some reason pulling over to this computer. Sorry, my IT skills are limited. Okay. Well, we may have small slides, but I can try to do my best. Okay, let's see.
Okay. Mm-hmm.
Let me go back to the Teams. Let's share again.
We can see your screen.
I'm not sure how. Okay, great. All right. Mm-hmm. So I'm gonna dive right in. So what I'm gonna talk about is kind of more of a protocol updates. I know we've had a little bit of already some discussion about the Neuro protocol, so we'll probably kind of skim past that. But I think I will dive right in. So we're gonna review the current standard ACR SBR imaging algorithm. Again, mostly for body, but a little bit of neuro, and if we've already covered it, we'll skip past that and then look at the newer child abuse imaging literature as well. So currently, as mentioned earlier by Dr. Holloran, if a patient presents less than 2 years of age, our typically first image recommendation for body is going to be a skeletal survey, of course. And then the neurologic imaging recommendation, we're going to have a low threshold for a head CT, depending on the age of the patient. The younger the patient, of course, the more likely a head CT would be recommended, because those kiddos have the neuro exam is not as predictable. And then additionally, consideration for brain MRI. So as probably all of you know, the skeletal survey guidelines include 21 images as a minimum. Here is the recommended positioning and the images. At IU, we do more images because we also include lateral views of the extremities. We have found that has increased detection, and it's been published in the literature, including by our group many years ago, to show increased specificity for diagnosing classic metaphyseal lesions. This is an 8-month-old male who presented with macrocephaly. His head percentile had increased from 15 to 97th percentile over the past 5 months. You can see the head CT looks like similar to other cases that we've seen earlier today. Because of the abnormal head CT findings, of course, the skeletal survey was recommended in this 8-month-old, and you can see additional injuries. So here we see an example of a left proximal humeral classic metaphyseal lesion with that kind of bucket handle appearance. Then additionally, you can see we have evidence of a healing fracture of the right clavicle as well. If you have a kiddo who's over age 2, you can do kind of focused x-rays if you can get a good physical exam and can kind of focus the exam rather than doing a complete skeletal survey. And again, if your neurologic exam is more reliable, you may not need head CT imaging. When we jump to a patient who has neurologic symptoms, of course, we're going to recommend a skeletal survey, and then additionally the head CT and is once more stable, an MRI brain and possibly spine. As we've heard, the brain MRI is going to add information in up to 25% of patients. The C-spine is going to add unexpected injuries in up to 36% of patients. And then I was going to review the paper a little bit here that Dr. Supakul referred to, which she already discussed regarding the thoracolumbar spine and what that also adds now that we have that data in the literature. So we'll look at that here shortly. This was a 4-month-old male who presented with bruising. And here you can see a bruise on the back of his ear. The head CT demonstrated a right parietal skull fracture. You can see the brain MRI showed additional findings that were not appreciated on the head CT, including hemorrhagic contusion in the left frontal lobe, as well as back here in the cerebellum. We saw hemorrhage along the tentorium, as well as diffuse axonal injury of the right juxtacortical white matter. So the MRI, of course, is, as we already know, more sensitive for intracranial injury. What about if we have a kiddo who were suspected intrathoracic or abdominal pelvic injury? That recommendation is going to be a skeletal survey as well as a possible CT abdomen pelvis with IV contrast. And then, of course, the neurologic imaging. So as Dr. Holloran mentioned earlier, if we're concerned about belly injury, we don't go straight to CT. But once it's suspected, and we'll talk about what that means in a minute, the recommendation is going to be a CT abdomen pelvis with IV contrast. So how do we suspect abdominal pelvic injury? It may be from a lab standpoint, so the liver enzymes may be elevated. It may be from the physical exam if there's abdominal bruising or flank bruising or abdominal tenderness. However, we do know this has a low sensitivity. And we do know that abdominal pelvic injury is important to identify given the high mortality. This is going to be second to only abusive head trauma in the leading cause of mortality in non-accidental trauma. Here you can see on this single slice CT image, this patient had diffuse liver injury as well as a right adrenal hematoma. This is a 3-month-old who fell from the couch. That was a history and presented with this radiograph, which of course demonstrates a significantly displaced and impacted mid-shaft left femur fracture. It looks acute. We don't see any evidence of bony bridging. On the skeletal survey, you can see there were additional evidence of healing fractures. So if you look here and try to, oops, I tried to zoom it up, but I'm failing at that. That's okay. If we look here, you can see evidence of healing left anterolateral rib fractures, and you can see some bone formation here consistent with healing. This patient had a laboratory evaluation which demonstrated elevated liver enzymes, and so given the recommendation, the belly CT with IV contrast was performed. And here you can see this patient had this hypodense round lesion consistent with the right adrenal hematoma. A little up higher in the chest, just to give you another image here, is that one of the examples of one of those healing rib fractures that we saw on the skeletal survey. What that kind of looks like on chest CT, you can see the bone formation here around that fracture. This is a different patient. This was a 2-year-old male who presented with vomiting. So maybe not a laboratory concern, abnormality, but a physical exam sign. And so the recommendation was for abdominal injury, abdominal imaging. And you can see on this belly CT, there was this abnormal hypodense area in the region of the descending duodenum, consistent with a duodenal hematoma. And here's what that looks like on the upper GI study. You can see there is contrast getting by the duodenum, but it appears quite narrowed and consistent with the filling defect here. of course, the most, this is definitely one of those injuries that is a red flag and typically occurs from blunt abdominal trauma. So looking at a child who's less than 2, who has a high suspicion for abuse clinically, but a negative skeletal survey. So what is the best recommended imaging for that patient? Of course, the most common answer and probably the most likely imaging to be done is going to be simply a skeletal survey follow-up. And so this is going to be performed about 2 weeks after the initial skeletal survey to look for evidence of healing fractures that weren't previously identified. The follow-up skeletal survey is very important. I would say the younger the patient, the more important it is. We tend to see even more findings in infants. We do see new information overall in about 12 to 34% of patients. The follow-up skeletal survey doesn't include all of the same images. We do exclude the skull, the pelvis, as well as lateral spine x-rays. There's some literature and data to support that these don't add anything really in terms to the diagnosis of new fractures on the follow-up skeletal surveys. Rib fractures are going to be the most common new fractures that we see. Those can be challenging to see when they're acute. So once we give them time to heal a little bit, we can see the evidence of the bone formation and can identify them. This is a 7-month-old male who presented initially with a head injury and a skull fracture. And so these were the initial skeletal survey images of the right hand and the left tibia and fibula. And you can see it wasn't until the follow-up skeletal survey that we had evidence of fractures, even in general, aside from the skull fracture. But we can see in the follow-up there was now a healing metacarpal fracture, as well as evidence of periosteal reaction consistent with the healing non-displaced kind of mid-shaft tibia fracture. So, for example, this would be very important because we initially had only head injury and skull fracture, no additional injuries, and now we have healing fractures in the 7-month-old. Additionally, on his initial skeletal survey, there was concern for fractures of the sternum, which were raised as possible fractures, but weren't called definite fractures. You could see this little bit of irregularity and lucency kind of at the manubrium. And then down here, there appears to be kind of a contour abnormality of a little bit of a buckle. On that follow-up skeletal survey, you can see some increasing sclerosis and evidence of evolution of healing of those sternal fractures. And so again, that was very helpful to say that this now, was a definite injury. Just a reminder, this is a 3-month-old with abusive head trauma, retinal hemorrhages, and multiple fractures. This is the initial skeletal survey at the top, demonstrating the kind of the classic appearance of a classic metaphyseal lesion with a bucket handle appearance of the distal tibia and kind of a corner fracture appearance of the distal tibia on the lateral view. So just a reminder that at 2 weeks, these can look totally normal. In fact, we looked at this and found that up to 20% of them appear normal on follow-up skeletal survey. And so this doesn't mean that the fracture wasn't real. It just means that it has healed. And so actually it's more evidence that it was a fracture because we see now that it has healed. So again, 20% of CMLs appear normal on the follow-up skeletal survey. Of course, we don't know when the fracture occurred, when the patient is presenting to us. And so it's still hard to know how one would date that. However, just know that they can appear normal, and that doesn't mean they weren't real. It just means that they have healed. Okay, so back to our kiddo here, where our initial skeletal survey was negative. They're less than 2. If you look at the ACR guidelines, the next 2 kind of recommended studies are going to be previously a bone scan as well as chest CT. So kind of let's look at both of these. Before we dive into that, we're going to switch gears from the current imaging algorithm to newer child abuse literature, because I think in the next guidelines that come out, these 2 images, there's going to be a little bit of change here. So I think we'll take this opportunity to dive into chest CT first. So chest CT has a few advantages. It has the advantage of time, right? So if we are worried about a fracture, let's say, of a rib, currently or previously we had to wait a couple weeks to look again, right, with the follow-up skeletal survey, or we could have potentially done a bone scan, which you'll see has a relatively high radiation dose, requires an IV, and is a little more time-consuming and challenging to do. So the chest CT offers the ability to immediately image the patient with no IV, right, and no sedation. The volume acquired, of course, is 3D, so we have volumetric images in which we can take a really nice look at the bones in detail. So we're going to look at the limitations of CT for detection of rib fracture. We're going to look at the difference between low dose and typical dose CT and understand the role that CT may play in identification of fractures. So this is just an initial equivocal case. It's probably really small on your computer screen, but there was just a this rib, which was the only finding on the skeletal survey. And when we spoke to the child abuse team, there actually was paraspinal bruising in this patient. So given the high concern, the same day we performed a chest CT in this patient, and you can see there were actually 3 non-displaced right posterior rib fractures identified on the chest CT, which were not seen on the skeletal survey. The patient did come back for a follow-up skeletal survey, and now we have evidence of healing in those same 3 fractures, confirming that those were indeed real. So chest CT is very useful. I think just knowing when to use it is the question that everyone has. If you look, there have been 8 or 9 papers in the last probably 10 years looking at chest CT. I would say these 5 have been in the last few years. And so really there's been a lot of work done recently on how we can use chest CT, and particularly how we can, how low can we go in that dose to still make a diagnosis. So if you look at that chest CT literature summary from 2008 to 2021, those studies had small numbers ranging from 4 to 25 positive cases for rib fracture. CT showed increased detection of fractures in anywhere from 17 to 40%. And doses were reported as low as 2 series of rib x-rays. Of course, CT doesn't only look at the ribs of the chest, but you can look for other fractures, including the scapula, and as we discussed earlier, the challenges with vertebral body fractures. So what did we do? So just share our experience here at Riley. So we looked from 2010 to 2019, over 10 years. We looked at kiddos who had chest CT within 3 days of initial x-rays. 41 of those chest CTs were performed at Riley, 9 were outside studies. 24 were a routine dose, meaning they were either performed in a series with the chest, abdomen, and pelvis, or they were performed for whatever reason with IV contrast, and 17 were our low dose protocol. 2 radiologists independently reviewed the anonymized initial x-rays, the follow-up x-rays, as well as the chest CTs. So we had 50 children with chest CT. You can see there were 29 males and 21 females, and the age average was 10 months old, and 27 of those patients also had follow-up skeletal surveys. So what did we find? So we found that chest CT significantly increased the detection of fractures compared to x-ray, which we knew, but we looked at both the initial and the follow-up skeletal surveys, and you can see initially chest CT found 112 fractures versus 42 on the radiographs. And even at follow-up, when you compared the follow-up x-ray, CT still did better in those 27 patients that had follow-up x-rays, detecting 93 versus 49 fractures. CT detected more fractures, 85%, in patients who had a positive skeletal survey than in those with initial negative skeletal surveys. So if the patient already had fractures, we are more likely to find more, whether those were rib fractures or whether those were extremity fractures. CT did miss one patient who had an acute non-displaced anterior rib fracture. So if you look at the location of the fractures found on initial x-rays and CT in those patients, it's quite interesting. CT detects the more specific fractures for abuse, including the posterior rib fractures, as well as fractures at the anterior costochondral junction. So these are quite challenging to see on radiograph, especially when they're acute. And so CT did better there. Also looking at compared to CT and the follow-up x-rays, you can see that, again, the costochondral junction fractures and the posterior rib fractures, the more specific ones, CT performed well better than x-ray. This is a case of a 12-week-old infant who had acute onset of nasal congestion and spitting up blood mucus. This was a radiograph from the ER. And you can see there was one healing posterior rib fracture identified on the x-ray here with this kind of bulbous appearance of the posterior medial rib. On the CT scan, which was performed, I believe, for the more so the respiratory complaints, you can see that healing fracture posteriorly, but we also see additional acute buccal type fractures of the left anterior lateral ribs. Here's the 3D reformat from that patient. And again, you can kind of see it is subtle, but you can see this buckle of the inner cortex of those two ribs compared to the normal ribs. So we're doing 3D reformats and all of the chest CT evaluations for rib fractures. And then this was confirmed on the follow-up skeletal survey. You can see now the healing at those anterolateral rib fractures that were not seen on the X-ray previously. So looking at chest CT, we found increased sensitivity of chest CT compared to X-ray for diagnosis of rib fractures. We found that CT detects more fractures not only compared to the initial skeletal survey, but also the follow-up skeletal survey. And then we found that CT is going to detect more fractures that are have higher specificity for abuse, including the posterior rib fractures and the costochondral junction fractures. CT, of course, has limitations, right? The big one is going to be the radiation dose. And then also, we have to remind ourselves and remember that CT actually has lower spatial resolution compared to X-rays. So looking first at the dose, so we try to calculate the CT dose for our 38 CT studies that were performed here at Riley in kiddos less than 3 years old. First, we, with the help of our physicist, Yoon, looked at the 4 views obtained from the skeletal survey and an infant or a kiddo, less than 4 years old. And we found that the average dose was 0.09 millisieverts, so the effective dose for these 4 views of the chest. When we looked at 14 low-dose chest CTs that we performed with a 10 filter, we found that our average dose was 0.032 millisieverts, so about 4 times that of the 4-view chest, still quite low. When you compare that to the routine chest CT dose, that's going to be about 12 times that of the 4-view chest with the average effective dose of about 1 millisievert. So the low-dose chest CT with thin filter is quite a bit lower dose than the routine dose. And in my opinion, it works quite nicely. Just to compare head CT dose to low-dose chest CT dose, you can see on average that the head CTs in these patients performed here at Riley compared to their low-dose chest CTs were about 8 or 9 times higher that effective dose. So how low can we go? We don't really know that answer yet. There's some data in the literature comparing low dose to routine dose imaging studies in adults, particularly for renal stones and for detecting lung nodules. There is a pediatric study in which they use a phantom looking for renal stones and trying to determine how low of a dose can be utilized, but that is something that still needs to be studied. So regarding the other limitation aside from dose is the spatial resolution, which is the ability to differentiate 2 adjacent structures as being distinct from one another. And so if you look at CT spatial resolution, it's about 1.5 lines per millimeter compared to digital X-ray, which is much better, 20 lines per millimeter, right? So this explains why CT can miss fractures, particularly if they're acute. And I'll show you an example of that. And we did have, again, 1 patient in our study. So this was a case, actually, Dr. Holloran has shared with me. This is a 4-month-old female who presented after her father had dropped her onto her back, and it was the second ED visit. And so there were images obtained from a skeletal survey. The radiograph was questioned as to whether there were possible non-displaced fractures. You can see the arrows here. This is the magnified image, and you can see maybe a lucency through the rib. But the radiologist was kind of unsure, and so we thought a chest CT would be helpful in this case, and the chest CT was performed in which the fractures were not seen. So I think this does fall into that category of X-ray in retrospect has a better resolution for CT because if you look, you really, you can see those lucencies in the rib. The patient had a 2-week follow-up skeletal survey, which now shows the healing callus quite nicely. So again, spatial resolution is a known limitation for chest CT. We had, this was the only case in 27 children who had initial skeletal survey, a CT within 3 days, and a follow-up skeletal survey, but it was 1 out of 27, so about 3.7% false negative rate for this study. This was the other case that I will like to present, again, from Dr. Holloran's patient. This was a 2-month-old detained due to domestic violence and substance abuse. And this was from the skeletal survey. There was a question raised of possible anterior costochondral junction fractures, which can be challenging to see on radiograph, but there was a concern. And again, here you can see there's arrows on the left side as well. The patient went on to have a chest CT, which you don't have the images included, but the chest CT was also called positive. It looked very similar to the radiographs, and the follow-up skeletal survey was normal. So this was a false positive case. We have learned a few lessons from this case. One, we didn't perform 3D reformats of the chest, and we did not perform axial-oblique reformats through the ribs. So we're doing that now in all chest CT cases. And then we're also double reading the positive chest CT cases like we do the skeletal surveys. So when to perform a chest CT? So if you go back to that original slide, you know, I think it was like the third one down, the third imaging recommendation for a patient who has a negative imaging but a high clinical suspicion. I do think we're going to see that change and kind of move up a little higher in line on the next guidelines as they come out. I think that kind of some smart indications for CT include 1, indeterminate diagnosis of rib fractures, 2, a positive x-rays when an additional rib fracture diagnosis could aid in diagnosis, because remember 86% of patients who had positive skeletal surveys had more fractures identified on the chest CT. So if you have fractures that are not specific for abuse, and a chest CT could provide additional evidence of rib fractures that may be more specific if that is useful for that patient. And then finally, a negative skeletal survey, but a high suspicion. So kind of jump gears a little bit. So we talked about chest CT imaging as a possibility for patients who don't have any fractures, but have a high suspicion for abuse. On that other graph included, there was bone scan imaging. So let's look at that. So radionuclide bone imaging adds confidence or new findings in about 12% of patients. This sodium, especially sodium fluoride PET, there's been more work done with this agent because they do use this still in Boston. This shows a greater sensitivity overall in detecting fractures other than the skeletal survey, specifically the ribs. It's very good for ribs, spine, pelvic, and acromion fractures. Of course, it requires venipuncture, sedation sometimes. It's not useful for dating fractures because the fractures can be hot, of course, for up to 1 year. And it has a lower sensitivity specifically for classic metaphyseal lesions and skull fractures. The big downside is the radiation. So if you look at the radiation dose of bone imaging, radionuclide bone imaging compared to the skeletal survey, you can see it's about 12 times that of the skeletal survey with regards to radiation dose. This is a patient who had X-ray and CT and had a very interesting appearance of the posterior medial ribs bilaterally. And so it was really challenging to know if this was kind of normal for this patient or if these were all very symmetric healing rib fractures. And so a bone scan was performed. I think this is the last one I remember being involved with, which was several years ago. And you can see that there was increased uptake bilaterally and symmetrically. And so these were definitely rib fractures. If you look at the literature for what has been looked at most recently with regards to bone scan imaging, there was a study in which they compared whole body MRI, skeletal survey, and bone scan in the setting of abuse. And let's see what they found. So they found that whole body MRI had a low sensitivity. This was a previous study. So previously what we knew about whole body MRI is that while we want it to be helpful, it's really not. It has a low sensitivity for classic metaphyseal lesions. You can see 31% sensitivity, and a low sensitivity for rib fractures, 57%. And we know these are rib fractures are the most common fracture that we see, and then of course these are both fairly specific. And so unfortunately, whole body MRI by itself has not really shown to be super helpful. If you pair it, however, with other studies, that changes. And so that's what they did with this study. So they looked at the sensitivity and specificity of skeletal survey alone, bone scan alone, whole body MRI alone, and then together. And so you can see that their bone scan alone had a very low sensitivity, as we might suspect, as well as whole body MRI. But when you compare it and add it to the skeletal survey, it does much better. So this, I think, is quite interesting. As far as looking towards the future, you know, perhaps there is some worth investigating more whole body MRI in the setting of skeletal survey. So jumping to head CT versus skull radiographs, again, diving into the new literature. If a patient has a head CT as Dr. Supakul mentioned, here at Riley, we get not only the axial images of the bone filter, here you can see the fracture, we also get the 3D reformats, which nicely show the skull fracture. And so if I showed you that slide again from the beginning that showed the recommended skeletal survey, you might say, well, that had skull radiographs on it. Why would we do skull radiographs when we're getting these beautiful head CT images? And you would be right. So there's been some work looking into, should we avoid skull radiographs in infants who also undergo a head CT, a no-brainer? I love that, kind of cute title. And the answer is probably yes. So CT has a diagnostic accuracy greater than that of skeletal survey in detecting skull fractures in this study. And even showed that that was increased if we had concurrent review of 3D reconstructions. There was a second study that looked at this as well, and they found similar findings that 3D CT had equal accuracy to skeletal survey for detecting skull fractures, and stated that omitting the skull X-ray would reduce radiation exposure without compromising diagnostic accuracy. So this has changed our protocol at Riley, and so currently, if the patient has a head CT with 3D reformats performed at Riley, we don't image the skull on the radiograph. Dr. Supakul touched on this. This is the study, a couple studies looking at whole spine MRI. This was the consensus statement on abusive head trauma in infants and young children. Dr. Holloran showed it earlier. And they, in addition to this study, understanding the importance of spinal injury and abusive head trauma, both advocate for whole spine MRI. And that is based on some studies, of course. Characteristics with spine injury on MRI in children evaluated for abusive head trauma, they found more likely to have spinal subdural and epidural hemorrhage compared with only those who had cervical spine imaging alone. And the study done here at IU looked at whole spine MRI, of course, as Dr. Supakul pointed out, with suspected abusive trauma, and found that a large number of the injuries, again, were localized to the thoracolumbar spine. Half of major findings were localized to the thoracolumbar spine, and vertebral fractures were identified, including 5 that were not identified by the skeletal survey, which I found very interesting. So whole spine MRI is now performed here. And if you look again at those consensus papers and other literature that's been published recently, the push is for centers to be performing whole spine MRI. This was a 6-month-old who presented with macrocephaly. So you can see, obviously, we have enlarged extraaxial spaces, but we also have some blood. On the whole spine MRI that was performed, you can see there is abnormal edema within a couple of these mid-thoracic vertebral bodies, which was very important because the skeletal survey was interpreted as negative. So there was no fractures identified at all on the initial skeletal survey. And we had big spaces, macrocephaly, and blood in the head, which, as we know from earlier, our differential could include Bessie. But the fact that the whole spine MRI demonstrated vertebral body fractures, which then in retrospect, looking back at the skeletal survey, I think you can appreciate some vertebral body height loss here. But the whole spine MRI was very helpful in identifying fractures in this patient who otherwise might have been thought to be Bessie potentially. So I think one of the questions with whole spine MRI is, what is the value of occult injury? And it's probably, kind of individualized per patient, but we would recommend whole spine MRI. So what is new with regards to classic metaphyseal lesions in the literature? There's a nice example of one. There was this paper published more fairly recently, which showed that subperiosteal new bone formation within the distal classic metaphyseal lesion, and they looked at the prevalence on radiographic skeletal surveys, and again found that the lateral views had significant increase in identifying this new bone formation, and they actually recommended go-down lateral views of the ankle, as they already do in Europe. So I think we could see this coming down the pipe as well with regards to the newer updated guidelines, that there will be recommendations to perform lateral views of the extremities, maybe not, the upper extremities, but perhaps even just cone down lateral views of maybe the knees and ankles. Long bone fracture detection and suspected child abuse. So this was a paper before I did my fellowship that the group here did, and found that lateral views did have significant increase in detection of the distal tibial CMLs. And so again, that's why we do lateral views. So I think in summary, the current protocol is skeletal survey, right, which includes 21 x-rays. Potential modifications include addition of the lateral x-rays of the knees and ankles, which would increase that number. The current protocol is skeletal survey plus head CT. And the potential modification is to avoid the skull x-ray if a head CT has already been obtained. And then the current protocol is MRI of the head and C-spine. And then I think a potential modification, or should be modified, is going to be with consideration for whole spine MRI. Additionally, the negative skeletal survey patient with a high suspicion of abuse, currently we recommend a follow-up skeletal survey, and then the next study recommended is a possible bone scan, but I think we can see that changing as well to include a low-dose chest CT as a potential option. So looking forward, I think specifically with regards to chest CT, I think using follow-up skeletal surveys and postmortem CTs are going to be helpful in determining the validity of those and when to use those, as well as studying both the low dose and the routine dose. And then I think there can be more work done with bone scan and whole body MRI, especially whole body MRI when compared with skeletal survey. It's interesting how it can do fairly well. And to look for these changes to be coming to the ACR guidelines. That's all I had. Hopefully my slides weren't too small. And if they were, I apologize.
Thank you so much, Megan, for the comprehensive review on the update and also the CT, chest CT things. Yeah. Any questions from the audience? Hey, Megan, I have a questions on the CT chest that you are doing. So which means it has to be like a very specific indication and it's like a tailor-made protocol, right? Because the radiation dose and things that we are going to give to the patient is going to be like a very low and specific just for the fracture. So you cannot see the detail in the parenchyma, like a lung parenchyma very well.
Actually, you can. You can see the parenchyma well. So you can look for other intrathoracic injuries. We know they're very uncommon. But for instance, things like you would think about with regards to trauma, right, including pneumothorax, pneumomediastinum, maybe, blood in the pleural space. Those things we're going to be able to see just as easily as you would on a routine chest CT dose. They are without contrast. So we are not looking, of course, at the vascular structures. The mediastinum is going to be really tough to look at as far as soft tissues. But with regards to the lung parenchyma and the injuries that we discussed, I think, it can identify those injuries. They're just not very common.
I see. Okay. Sounds good. Any questions? Okay. So someone said, so question from Chris Newman. So he asked, do you think there are any advantages of this chest CT over the follow-up skeletal survey?
Do you think there are any advantages of chest CT over follow-up skeletal survey? Yes, I do. I mean, well, the big one is time, right? So, and Dr. Holloran can chime in too as far as the clinical piece. But if you have a patient in which perhaps the child abuse protective team is unclear as to what the recommendation is going to be as far as the patient disposition, if the chest CT can help that same day or the next day, provide more information for that decision to be made rather than waiting 2 weeks and maybe not knowing what we're going to find in that follow-up skeletal survey in 2 weeks. I think that's the main advantage is time. Again, looking for other fractures is also useful, ones that are difficult to see on the radiographs, scapula fractures, sternal fractures, vertebral body fractures. These are not common, but they are specific for abuse. And so I think that chest CT is going to aid with that as well. And then in the future, if we can get a chest CT that's, as low dose as 4 views of the chest, would the chest CT replace those 4 views of the skeletal survey and then obviate the need to do the 4 views on the follow-up skeletal survey? So could the chest CT take place of those 8 radiographs and give us, more specific answers? And no, I think these are all interesting questions.
Yeah, Megan, to add on to that. Oh, sorry.
Yeah, Tara, go ahead.
Yeah, I just wanted to reinforce what you said. The timing is huge. If we have possible injuries, DCS is not typically going to intervene based on that, based on possible injuries. So we have had children where we were concerned about possible injuries and planned on a 2-week follow-up skeletal survey, and they were killed before they could come back. So it's if we can be definitive at the front end, that's much more helpful as far as protecting the child if that's what they need.
Yeah, that makes sense. Yeah, that makes sense. That's why we need to make a definitive diagnosis as soon as possible.
Yeah, and on the other side, if it's not an injury, we don't want to remove kids from their homes. We don't want to put them in foster care if they really don't have an injury and don't have a reason for concern. We don't want to be putting kids in foster care for no reason. That's harmful too in a whole different way.
Sounds good. Thank you so much, everyone. Seems like we don't have any more questions. So I would like to thank Megan and Tara for joining us today, giving us overall lectures on the child abuse thing. This is really helpful and make us as like a well-rounded radiologist to see things, and at least we can see something beyond just the film. We know the clinical history, how to put the appropriate wordings in the report, and what like the next step to recommend people. Even like this lecture a little bit beyond for the neuroradiology fellows, because there is a lot of clinical aspect and also the body imaging. But I think I still thinking this is really helpful for us, at least to learn from like different angles or aspects. So thank you so much, everyone, for joining us today. And we're going to have the last session for the Learning with IU next month with Dr. Wu and Dr. Walsh about the white matter disease. And for today's study, I am going to send out the evaluation link to you guys. So at least you can give us an evaluations. And we also have the CME credit that you can text in to get the CME credit for these 2-hour lectures. And for the people in Thailand, you can also get the evaluation form via your email and please complete the evaluation form by Friday to get the CME credit from Thailand.
Done.
Yes, thank you. Bye-bye.